Okay, is all right?
Yeah.
Start now. Abhishek, is all right? Abhishek?
Perfectly, sir. Perfectly, sir.
And connect to YouTube?
Yes, sir.
Thank you very much for all the speakers from the UK and the New Delhi, Dr. Saini. And is a COVID era, and they kicked into loss of the oldest person, and everybody knows what is the corona. Up to now, he is only one hero, like a Bahubali, only some of the people, but this is more than Bahubali. And everybody knows that who is corona, what is corona, what it is. And now the people are realizing now how bad it is also. Like that, now to make the what is the clinical features and what are the effect of the things, how we can resist the corona, how can we practice and how to do it, and what is the national scenario or the international scenario, like the total roundup we want to make it. That's why you made this program today. I think with the Rajahmundry IMA and GSL Medical College, this is the second program what you are doing from Rajahmundry. I think I think it's interesting to most of the practitioners in Andhra Pradesh and part of the South India and part of the North India, because here a lot of surgeons also involved. Some of the 30% will go to surgical aspects, and 30% will go to the general practice and how to practice other things, and the remaining 40% will go for the what is the actual scenario. Now I'll hand over to the mic to Dr. Murthy. He's a surgeon, and Murthy.
Thank you, sir.
Forward to you.
Thank you very much. We have a panel of speakers here. The first panelist is Dr. Anwar Qureshi. He's a consultant acute physician and clinical lead for acute services at North Lincolnshire and Gould NHS Foundation Trust. Anwar.
I think he had stopped the slide show. Oh, he started.
Anwar, please unmute yourself.
Good afternoon, and I'm Dr. Qureshi. I'm a consultant acute physician at Northern Lincolnshire Foundation Trust. And what we're going to talk about today is some considerations that we had to go through when we were hit with COVID. Preempted that we were going to be hit, and then we were hit with it. Luckily, the peak has now gone and the numbers have reduced. But what I'm going to do is just summarize the considerations we had to make on a more organizational base, on a more personal base, and what did we have to do in terms of treatment of these patients. So the learning objectives today, are to understand, learn that general principles apply in reducing transmission of SARS-CoV-2 and management of COVID-19 when it happens in. And what does the future look like for us, particularly in relation to how it looks like in the world and how it looks in the NHS here, because we run a public health system. Obviously in India, you run a big public health system, but there is a big private sector as well, which is involved in caring for these patients. And at the moment, obviously, nobody has any choice. So we'll tackle that. But first of all, we'd like to talk about what challenges we faced. So then one by one, I'll talk about how we dealt with it. One problem that our countries have is when this kind of thing hits, the private sector sometimes tend to work on their own benefit rather than the whole population. So that's something to fight with and discourage, in fact. So the first foremost challenge that obviously India would be facing, as well as, I'm from Pakistan, so they are facing, is a population has denial of the disease existence. There are asymptomatic carriers which pose a threat to the spread. There is cross-contamination on surfaces. There is risk of transmission from patients and healthcare professionals within the hospital. Obviously, we do aerosolized procedures. And then we are tackled with the availability of health services not sufficient for the population we have. Obviously, India is a big country. As I said, government and private setup, but still, the resources are limited. Similarly, in UK, NHS is the biggest health service, but still we felt that the resources were limited. Always the problem being the availability of PPE. And then the main problem was how to actually treat this condition. Nobody still, okay, there's some evidence, but not really enough. And how would it impact the future? So if we talk about denial of the disease existence, now it's very evident that, the disease is there. You've got about more than 6 lakh cases in India now. We've more than 3 lakhs now. You see that, there were a significant number of near 400 deaths yesterday in India and about nearly 100 in UK. But the good about the statistics that are from India are that the recovery of these patients is quite significantly more than what's happening in UK. So you can see the graph on the right bottom. It shows you the recovering patients. So actually, as the incidence is rising, the recovery of the patients is also rising. Right. So that's the case. But you have a peak at the moment because you can see that the daily new cases are still rising. And we've had our peak and which has gone down. And then suddenly we've come across now hotspots in the country again. So the second problem we face is the asymptomatic carrier. Now the carrier state exists about 35% of the population who can shed virus and spread. In the Journal Nature Medicine also suggested that actually those who are asymptomatic can still develop mild lung damage. And recently Indian publications suggested actually 100 out of the 100 infected, 80 were found to be asymptomatic. Now, there are some studies that suggest that some of these patients would later on develop some symptoms. So this is a population that exists and goes around your hospitals, comes in outpatients, then you see them on the street, but they are asymptomatic. And that's where the spread comes. Now, I understand recently WHO changed their statement and said actually it's unknown and maybe the spread from asymptomatic carriers is small. That created a lot of confusion to say why then masks in the public. Actually, there is no evidence yet to say they are not infecting. Obviously, then the symptoms that people develop most commonly, the major fever. So there is cough, fatigue. And recently we've seen that loss of taste and loss of smell has come in. So a lot of people have experienced only minimal symptoms. So they've been at home and they've said, oh, I lost my taste about a few weeks ago. Actually, they may have had COVID. They may have been, carrying it, and they would have spread it to other people. But the good thing about the subcontinent is that actually the recovery rate is better and mild disease is much more than what we've seen in UK. So then is the problem that, the virus stays on surfaces for a very long time. And you can see how small it is, obviously. So what to do with that? Because when the patients come into hospital, we are this problem that everywhere you touch will have the virus if you are carrying it. And then if somebody comes and touches, it spreads. Now, obviously, it's aerosolized as well. So, if somebody coughs or sneezes, it goes into the environment. But there is a relationship to distance, which is where the science behind social distancing came, is that after 2 meters, the bigger droplets actually fall down on the surfaces or on the floor. So if you are more than 2 meters away, actually, you have minimal chance of having it. So although we use masks, but distance is more important than actually using masks only. That's the problem we face, so there's cross-contamination, and you can see, the good studies have been done, which suggest that it can sometimes, the aerosol can remain in air for 3 hours. On copper, it can remain for 4 hours. On plastic for 2 to 3 days, and on stainless steel for 2 to 3 days. So these surfaces need to be wiped again and again and again. So we can strategize, and this is what we've gone through. The bigger problem has been to prevent the transmission of infection between patients, from healthcare professionals, and between us. So there are two ways of dealing with that. One is look after personal protection, and the second is to do a more generalized hospital transformation or transformation in the healthcare setup to prevent this and to deal with these challenges. So in personal protection, obviously, we talked about safe distancing. And as you can see, we are having this conversation online. Even meetings are happening online. When we sit in a room, we are socially distant. We're not allowed to even going to canteen. We are socially distant. Avoid crowding, which comes hand in hand with that. Hand hygiene, the most important bit, and not touching your face or eyes in any context. PPE, which, some of you were wearing a mask just now. I as well had to take it off. And then remote working, as we are doing now. So a lot of people like, Purti would tell you that we have been doing clinics which are remotely done. So on telephone or on video consultation. The other thing is where there are crowded areas. So for example, you are on call, you're an on-call team, cleaning off the surfaces again and again. So if you've shared a workstation, you get off from that after cleaning it. And then touch points like doorknobs, computers, the swipe card areas, the vending machines, all of those need to be cleaned every 4 hours. So this is a bigger strategy in terms of in your healthcare setup, what you need to do. There is the staff risk assessment, because some of us are more prone to the disease than others. So those of us who are more prone to disease need a specific assessment tool. So recently, SARD tool has been introduced for primary care, and another tool, our trust and other NHS organizations are introducing for particularly in UK, because we had the problem with 340 healthcare professionals, well, actually 340 doctors dying, 600 something healthcare professionals dying of COVID, that we realized that actually the incidence is much more in non-white individuals, which was the BAME word they used. I don't know whether it's politically correct or not, but that's the strategy. So the Black and Asian ethnic minority group. So then we realized actually, yes, if you're a Bangladeshi, you have twice the chance of getting COVID. Indian or Pakistani, you have 20 to 50% more chance of getting coronavirus. If you're a Black African, your chance is even 3 times. But that's statistics. Whether it's the strain that's in UK or whether it's the phenotype of the population in UK, we don't know yet. Clearly, more people are having mild disease in India. Where there are multiple people, obviously, where people have installed antibacterial screens. Now, with personal protection, the main thing to avoid spread to your own colleagues and patients is that if you are sick, you isolate for 7 days until you get better. If your home is sick, you isolate for 14 days. And if you've been exposed, you go off for 14 days. And if you develop symptoms, then that's it. But the bigger strategy is to protect the patients and our healthcare professionals was to do it more on organizational levels. And that came from the National Health Service in late March, April, that actually we need to, so that we have 4 different pathways for different type of patients. So we have the green zone, which is completely COVID-free. So these are patients who are asymptomatic, and initially they were just asymptomatic. We weren't testing them, but now we are testing everybody. So these are patients who are asymptomatic and test negative. So PCR, respiratory tract PCR negative. Then is the yellow zone, which is for patients who are asymptomatic, but we haven't yet got the test result back. So these are patients who present with other conditions and not with COVID symptoms. So we put them in an area, in an assessment unit, which is a yellow area, and then we treat them for their condition that they've come with. Do not go on COVID treatment or anything like that, but we wait for the test to be coming back. Now, some of them have had positive tests, and then we move them to the red area, but some of them will come back as negative tests, and they will move to the green area. Touches A&E in our hospital, they are divided into 2 groups to say, have they got symptoms? Have they not got symptoms? If they've got symptoms and they are significant virus infection or COVID-19 disease, they go into the red area in A&E anyway. If they are symptomatic but not very sure, they go into the yellow B area. And if they're asymptomatic, they now go into yellow A area. There is no green area in A&E now. Subsequently, they then get to assessment areas for the specialties, whereby asymptomatic ones go to the yellow A assessment and the symptomatic ones go to the yellow B assessment area. And subsequently, if the test comes back positive, there is a red area, which normally is our respiratory ward, which is where they go. So this is the biggest consideration in managing these patients, because the treatment side of things has little role. It is the prevention side of things and reducing contamination that has the major role. So revised hospital footprints, staffing. So we went on different rotas, in fact, because you see the evidence. You are more likely to get infection if you are exposed more, your viral load is more, and if you are tired and stressed. So if you ran the current rotas, a medical consultant on call would do a 12-hour shift and overnight on call and be at work next day morning. So we tried to change that. So during the peak period, we had a split rota. We had a COVID team and a non-COVID team, and that reduces the exposure, reduces the use of PPE, because only one team will go to yellow B and red zone, and the other team will only go to yellow A and green zone. And that helped a lot, and people rested as well. So that helped. Screening and swabbing. So initially, when we had lack of testing ability, or rather minimal testing ability, we were only testing symptomatic patients. But now every patient that is admitted to hospital is tested, which makes it easier to have these zones. And then is that a question? Somebody raising hand. Okay, sorry, adjusting. So the next step is NHS test and trace service, which unfortunately the application that they used is not completely working at the moment. But apparently 60% of the population is registered with that, which is to say, if you declare your symptoms, you'll be tested and your contacts will be traced, which may help in future. And then every hospital needed incident management team. So we have a control center which looks at the whole picture of the trust in the morning every day. And that is more important, and you need leadership in that to deal with anything that's unusual, the number of patients going through, how the zoning is being kept. And sometimes, initially we had to increase the red zones, and then now shrunk and gone to 1 ward. We were in 3 wards previously. Now the red zone is in 1 ward and the rest of the wards are green. What we do in green zone, there's no COVID patients. So what kind of PPE do we use? So gloves, a plastic apron, and a surgical mask. If you do aerosolized generated procedure in a green zone, then it is supposed to be in the side room in a normal way as it used to happen pre-COVID. Then is the yellow A zone. The PPE is similar with a visor or a front screen because of the asymptomatic patients who may sneeze or cough, and then you need to have droplet protection. Yellow B zone, the PPE is still the same, in which is your ITU setting and your respiratory ward and confirmed COVID cases. If you're if you're not in an aerosolized area, so in the ward where the patients are, but there's no aerosolized procedure, the PPE is the same as yellow B. But if you're doing aerosolized procedures, aerosolized generating procedures, then you need a full gown, a FFP3 mask, and a screen in front. So the problem now recently, as Murthy would tell you, that we've been facing is that aerosolized generating procedures are many. From doing some of them, which are diagnostics, unless it's really urgent and cancer related. Obviously, one of the most important aerosol generating procedure in our practice is ventilation itself. And a lot of these patients do require that. So as you can see in the diagram, now nebulizers, it's controversial whether it's aerosol generating, but certainly if it's oxygen driven with the pressure, then it is aerosol generating. In terms of the NHS guidance, they have suggested that nebulizer isn't an aerosol generating procedure if it is not driven by oxygen, because it's in a contained in the environment. Have to be careful, because if it's driven on oxygen, then it's under pressure and it is aerosol generating. Invasive ventilation, obviously. So now, recently the Research Council issued guidance as to how to ventilate these patients. So a closed loop invasive ventilation. Now, recent evidence suggested that invasive ventilation has been delayed because initially people were early intubated and they had outcomes. I'm sure Sandeep would tell you about that bit. Non-invasive ventilation, obviously CPAP has been used very commonly now for management of these patients. It is an aerosolized generating procedure. CPR itself, so Research Council again issued guidance that actually, unless you are in proper PPE, irrespective of what time it gets, you do not start chest compressions. Endoscopic procedures all have been on halt. So availability of health service obviously is limited everywhere. So we need to be doing all these measures to make sure that actually there is no peak and we disperse it all so that the system can cope with the problem. PPE is an issue, so how do we deal with that? What do we need to minimize the number of individuals who need to use this? Okay, so instead of using, the house officer seeing the patient, the registrar seeing the patient, and the consultant seeing the patient, so 3 lots of PPE is being used. We resorted to that the A&E doctor saw the patient, and then straight away we see them as a consultant. And that's really it. So only one junior, then one senior sees the patient. So that reduces the number of PPEs used. Prioritize who uses the N95 respirators, because obviously they are gold dust. So the highest risk population, so this risk assessment we've had done, which suggests that some individuals will require enhanced PPE. So those individuals can use N95 respirators in the areas where normally people would use surgical masks. But also, it has to be rationed, obviously, in national health systems. Then, as I said, minimize the number of healthcare professional contact with the patients. And that's the only way to reduce the use. 95 mask, just a brief, I won't go to the whole slide because we've got restricted time. You can for a sessional use, it can be used up to 8 hours, but mind you, skin gets affected. So we give 2-hourly breaks to people who use it. Now, the manufacturer recommends we only use it so either extended use or intermittent limited use. So people carry the 95 masks and they use up to 5 times on every session. But there are strategies to save these. So storage, you've got to be careful with. You put them in a bag, you label them so that nobody else uses them. If this has been in contact, even if you've got sessional use or a limited intermittent use the trust has given you or the employer has given you, if it in contact with AGPs or aerosol generating procedures done, then it needs to be discarded. If it comes in contact with fluid, it needs to be discarded. So the major thing is if you're doing limited intermittent use, that's the term being used, then you have to be avoiding contamination of the mask. That means washing hands before and after. There's a difference between the surgical and the N95 mask, obviously, because the N95 mask will protect you against smaller particles and organisms. There are various types available, so not going into the detail. Then major problem, because how to actually treat once you've got a patient and who to treat. So what you need is care pathways. So we've developed a care pathway for COVID-19 patients, which is very specific, related to patients who come with any symptoms relating to the case definition of COVID disease. So, and the guidance we have from our National Institute of Clinical Excellence is that you have to have a treatment escalation plan for every single patient that comes in, because you have very limited resource at level 3 beds, which are HTU or ITU beds. Hence, you have to make the plans at the outset to say what will happen when the patient deteriorates. And who do you admit? So we can't admit every patient to hospital. So the simple common sense guidance was that somebody who's hypoxic, somebody who's tachypneic, high respiratory rate, somebody who's got X-ray changes or has a high mortality from a pneumonia, which means a curve 65 score of more than 2. So that's the simple criteria we use to admit patients. Everybody else go home with advice and come back if they were worsened. Now, the severity of illness, as I said, 80% people will get acute, mild or moderate illness. They don't need to be in hospital. The ones that need hospital, 15% are severe. Only 5% get to intensive care unit. So, when it's talked about in the countries and by politicians, everybody talks about ventilators, but actually the masses of the population will only get mild, moderate illness. They just need to be cared for at home. They need to have the right advice. So that's the main problem. Now, when they come to critical disease, there are two different types of that the lungs can have. One is acute viral pneumonitis, and the second is adult respiratory distress syndrome, which is from the inflammation relating to the virus. And then you can have organ dysfunction, and the worst bit that kills people is hyperinflammation syndrome, which is your body's response to the illness. So what do we do to investigate? Obviously, the PCR, respiratory tract PCR, it has 20% false negativity. Chest X-rays would show you bilateral patchy shadowing, either a pneumonitis or ARDS. CT chest in routine is not required. One reason being that contrast leads to risk with nephropathy. So we don't necessarily give contrast even if we do a CT scan. If at all you want to know, then the best thing is to do a HRCT, which is non-contrast. In bloods, the most important bits are, low leukocyte counts, the creatinine kinase if it's raised. Troponin, we don't usually do it unless they've got chest pain. Severity of illness markers, which is the main thing to look at, is which tells you if the hyperinflammation syndrome is actually ferritin LDH. And obviously, recently, the postmortem studies from Italy showed that there were fibrin products within the vessels and clots, which then led to the notion of anticoagulation. So then measurement actually helps you to deal with that, and there is recent evidence for that. Sorry. And how do we manage? So the mainstay of management is oxygen. Now, avoid high flow nasal oxygen. Because initially, when we were preparing for COVID, actually, believe me, for 20, 30 nasal high flow machines, and I don't know about 30 or 40 BiPAP machines, in fact. And then we had to stop because as the evidence, we realized actually a closed environment ventilation was much better for these patients because it reduced the AGPs and reduced the exposure. So if you needed oxygen, you give normal oxygen. Then the second evidence was for proning, which is up to 16 hours prone posture, which helps oxygenation. And the next step in non-invasive CPAP, hooded CPAP. You can see the picture. I've been a patient and I've had that as well. So it's not now uncommon. We've had more of these, which is easier to do, easier to tolerate actually. Unless patient has acute respiratory acidosis, in which case they can use BiPAP. Avoid fluid overload. Do not give, antibiotics only if bacterial infection. Now, obviously on intensive care unit, by that time, people have been in hospital for a while and stuff. So they are covered with antibiotics, but not routinely. They should not. Now, then we come to antiviral medication, which remdesivir is the only medication which recently showed a reduction in hospital stay in critically unwell or ventilated patients. So it is used, it's a nucleotide, in fact, analog, which works by inhibiting the RNA polymerase, but it's used with caution in hospitalized unwell patients. In non-ventilated patients, only for 5 days, so a 200 milligram dose initially and 100 milligrams after that, and use for 5 days. In ventilated patients, you can use it up to 10 days, but it's a very small selected group of patients because the study actually had a very small number of patients in it. Then currently, the most important progress that we are making in UK is the recovery trial, which is the randomized evaluation of COVID-19 therapy. It has already shown that there is no benefit in two drugs, which is the lopinavir, ritonavir, which were the anti-HIV agents, and the hydroxychloroquine. So there's no benefit of those. There is, however, of low-dose dexamethasone, which is 6 milligram once a day for 10 days, in reducing mortality by a third in patients who require oxygen or are ventilated. There is no yet, and these are being tested, which are azithromycin, tocilizumab, and convalescent plasma. Now, when we talk about tocilizumab, there are 3 trials that Roche, the company that makes it, the Actemra, is doing. And doses they are using is in a patient who's got more than 30 kilogram weight is 200 one dose or 200 milligram 2 doses. But one of the trials in Mariposa, I think, is using a big dose of 400, but there is no evidence yet. Now, the Chinese study that had only 21 patients actually showed that the patients who were ventilated came off the ventilator 4 to 5 days earlier than the compared population. Convalescent plasma, again, the Chinese trials showed no benefit, but the American trials showed some benefit. Recovery is still testing it. Anticoagulation, as I said, it's the evidence was reviewed by Imperial College, and based on the postmortem studies, we now have clear guidance with us to say how much anticoagulation to give based on the D-dimer levels of the patient. So if you're less than 1,000, depending on weight, so you give small doses, but actually if your D-dimer level is more than 1,000, then you're on treatment dose of low molecular weight heparin, mainly being used as enoxaparin. So that's about all the problems faced. Obviously, what happens in future? What will it look like? So I think social distancing will still exist. PPE we will continue to use because even though we'll get rid of COVID, there will be some hotspots and some prevalence of the disease in the population, unless we have a vaccine, and we still don't know whether the virus would mutate. So the vaccine will need to be every year. Remote working, now we've got used to all of this. So this is very good. Now, I couldn't have imagined presenting in India. So I can do that now. And zoning will exist. Now, the one thing I'll tell you about zoning is, instead of having 4 zones, we may go to red and green if we get point of care testing. So if you had point of care testing, which means that you test on spot and realize patient negative goes to green and patient positive goes to red, then that bit of structure change will be reduced then, and you have more space for those patients. Track and trace obviously has been proven effective, particularly in countries like Korea. You can see how travel and hospitality industries, it will always be affected by this now permanently. I think the most impact it has got is on economy, and particularly health economy. We will all need to be psychologically recovering. A lot of health professionals need a lot of help at the moment to recover from this whole thing. Our National Health Service has given a plan, which is to do NHS reset. I don't know how they're going to do it, haven't got the money, but restoration and recovery is on course. And they've given 4 stages or 4 phases of this to say, how would we develop our health system to cope with the NHS, which is in this slide. And apparently from April 2021, business as usual COVID-19 service in place, including sufficient critical care headroom. So Sandeep will talk about more about critical care, but we've had to expand our critical care at the expense of our elective work. So, you know, our ventilators went into theaters so that we can accommodate more patients. So the elective work stopped. Now that the elective work will come in, we'll need to think about whether we need bigger intensive care units. So that's the plan. And then this is how hopefully future will not look like. This is how it will be still, I think. And you'll go to restaurants like that, or in aeroplanes like that, or at workplace, or in schools and colleges like that. And you'll eat like that and exercise like that. Thank you.
Thank you, Anwar.
Thank you very much, Anwar. Fantastic show. Let Shiny introduce the things about the COVID in India and other things. Shiny, take on. Shiny?
Can you hear me now? Thank you so much, sir.
Yes,
I think Dr.
Yes.
Thanks, Dr. Qureshi. So elaborately done that I think everything become very clear to us. We know in the world, as you rightly said, there are 11 million cases in the world. 5 lakhs people have died in the world. And if we talk about India, 6 lakh at present today figure is 6.25 lakhs of people are suffering from COVID disease, and 18,000. That's a good point, is that 18,000, though it is data, but I know every death counts, but still we have to figure it out that how many deaths have happened. It is 18,000 deaths which has happened, which comes out to be roughly around 3.1 fatality rate, which is, I think, if we compare the world, it is much less, which is around 6.13 in the totality in the world. So we have around 3.1 to 2.8%. So I think that way it is fairly good. Now we have 3 or 4 states which are, I think, the number of cases are rising. If we talk about first and foremost is Maharashtra, where at present Tamil Nadu is higher than Delhi. It is 98,000, and then Gujarat, which is 32. These are the 4 states which are now at present in this having number of cases which are increasing day and day. The only thing, I think the problem in India is at present we are reaching to peak. We are number of cases are hiring and going high and high as compared to UK, where you have almost able to flatten the curve. Here is a challenge here. And secondly, number of tests are also being increased, but not in a way which should accommodate the population which we have got. So that is another challenge. As you rightly said, there are other challenges everywhere in the world, and that is there in our country also, like the spread of the disease in asymptomatic patients. India has a wide variation in the population, metropolitan cities, semi-urban, then rural, and unfortunately at rural areas is very difficult to reach. No doubt there, the distance, physical distance is there automatically because of population is less dense over there. But then the challenge of there is that there is no hospitals over there, and there is another problem is that the testing is also a problem there. Then rightly you pointed out, we have challenges on antiviral drugs. We don't have as such a standard protocol of having some of drugs. Then there are problems. Like, I just want to have your point of view also, Dr. Qureshi, like you said, of testing. Now, if we are having one antigen testing also, which is a rapid at the point of care test, is it there in UK also? Is my question to Dr. Qureshi. We have introduced just now a antigen test, which is not an RT-PCR test. It is a point of care test which takes around 25 minutes. Is it there in our country also, and what is your take on that?
Yes, so antigen testing has not started in NHS yet. This is something that, well, they are trying to introduce it in late August, September. What type of test it would be, we are still not very sure. But at the moment, we are not doing it at the moment in NHS.
And what about your antibody testing? Because India has started doing antibody tests, but it is not available for the labs to do it. Only on the government is doing only in certain containment zones.
Antibody testing currently is being done on NHS staff. And there are some antibody kits available commercially as well, which, well, the National Health Service had approved them, but the reliability of them, two companies are marketing them, Roche and Abbott, but the reliability of the tests are still not, there's not much surety on them. But the ones that the NHS itself is doing it on NHS staff at the moment. So we've all been antibody tested. Now, currently it's being done to look at the disease prevalence. It has no benefit yet until we actually have evidence that the immunity would last. Because you see, if you think the coronavirus is working like a cold virus, then you may be immune to it for 2-3 months, and you may have reinfection after that. So the thing that needs to be seen is, does the antibody last that long? And that's what we looked at. So hopefully, once the whole NHS population is done here, the healthcare professionals, then we get tested 6 months down the line to see actually how many of them obtained it. And also remember that, for example, for hepatitis B, some people are poor responders. So they get boosters every year because they never mount an antibody response. Some of our colleagues who've had COVID, who are positive, have now come back antibody negative. So either the test is false negative or they've been poor responders. So actually, practically speaking, to change practice, currently the antibody test didn't make any difference to our practice. To say, no, you are immune, you can use less PPE. That cannot happen till we know that it's permanent immunity.
So I just want to make it more clear. It means you are not, as a doctor, you are not advising for an antibody test. It's only by the NHS for mass.
So we are doing it for masses to look at the disease prevalence in healthcare professionals at the moment. And then
disease prevalence, or it is the amount of antibodies they are having?
Amount of antibodies generated.
I'm not sure I understand.
So you touched upon another thing, because nowadays in India, we had a lot of political, I think, there about plasma therapy.
Yes.
Not more by doctors, but most of them hype is created by the politicians in India, that plasma therapy, plasma banks, and so many things are happening in the country.
People are making money on it.
Plasma therapy, Therapy,
Okay.
whom you
So
give, what at
by
what time
far,
of the disease to be given?
yes. So by far now, obviously it's in our area, it's being given as part of the recovery trial. And on June the 3rd, a child was given in our region plasma and had actually improved. So that's the only thing. The trial evidence is still not out. The other evidence that's available, as I said, is from the Chinese trial, which although the eventual conclusion of the trial was that in moderate to severe disease does not have much impact. But then again, they showed that 5 or 6 patients had reduced length of ventilation. So there is still some evidence there, but it's not significant to give it to the masses. Then also the use of that should be only in moderate to severe disease. But if evidence comes, now the evidence till now suggests that there is no benefit. There is no benefit. It should only be done given under trial situation. So because you see, it's different. Our health system is very different. We cannot use anything on a patient basis based on our own opinion or advice. It has to be evidence-based. Whereas in some countries in the world, people would use it on the basis of experience. So if somebody gave 4 people plasma and their patient, 3 patients improved, that person may carry on giving plasma to people to say, no, my patient, 75% improvement in my patients. But we've not given plasma to anybody in our hospital ourselves. Sandeep may be able to say that whether they've given it to anybody on ITU. I know that some patients on intensive care unit have been given in the region some convalescent plasma, but we haven't certainly.
And another question is that when we are giving plasma therapy, convalescent sera, how much should be the antibody titer where you say that yes, this is the person who can give this kind of plasma therapy?
So I have had no experience in that, which is why I can't answer that question.
Okay, fine. I think the things which we have not have an
experience. Steiny, you'll do next person, and the Muthi, what you'll do, Muthi will introduce the person, because directly the person is coming, that like that it will go. The person should be introduced to the audience also.
Thank you.
Muthi Garu.
Thank you, sir. The next person is Dr. Sandeep Saxena. Dr. Saxena is a senior anesthetist and experienced hand at this. Floor is yours, Dr. Saxena.
Is ready?
Yeah, just a minute. I will be ready for you in a second.
Yes. Good.
Yeah.
Excellent. Just to add to what Anwar has said, Anwar has put a very good presentation together, and he's actually covered a lot of information that's really important for SARS-CoV-2. I'm covering a very brief area, which is what we expect to see with anesthetics and critical care, particularly in the post-COVID area. So our concerns right now are slightly different. When the pandemic started, we had to do a lot of things. We had to change the way our staff work. We had to go to teams. Many anesthetists, as a rule, tend to work individually, but now we had to bring big teams together. We had people from other specialties. We had ophthalmologists working with us. We had medical students working with us. So we created bigger teams that helped out in intensive care. A lot of staff centralization happened as well. In the UK, there is a golden word called job plan, which is how each one of us works within the government setup. These were all suspended, which by itself is a very big thing. Then we also had to deal with the equipment to expand our intensive care capacity. The target was that we go to 3 times the installed intensive care capacity. Now, the UK traditionally has a very low intensive care bed base, which is about roughly 1/4 of that of, say, Germany. But India is actually even smaller than that. So that is obviously an issue. Fortunately for us, India seems to have less fatalities than the UK has had. So we all of us hoping and praying that it stays that way. But as of today, as pointed out earlier, we are clearly up to almost 16 or 17,000 deaths in there, and the population has not really infected in the way it could have been. So we still have to watch that. But in the UK, we expanded to 3 times the intensive care capacity by taking up operating theatres, by taking up any level 1 or level 2 bed spaces, which are high dependency beds, or even anesthetic recovery areas. We retasked our anesthetic machines, we took all the CPAP devices, we took syringe drivers. In effect, we kind of created field anesthesia, a bit like anybody who's worked in the military would know. So when you are in the field and you're up in, say, the glaciers up in opposite the Chinese, if you have casualties, you have to expand. That's exactly the kind of work that happened here, except it was slightly more organized. As a result of this SARS-CoV-2, what we've noticed is there's about a 40% reduction in patients coming to the hospital. Implications of that are quite dramatic for us as a society. We have an older population, we have a frail population, we have people who have significant multiple comorbidities. So all of these people are not only getting frailer, their disease conditions are not very well controlled. So the diabetic who's got a borderline HbA1c may actually worsen. Then we have the results of the lockdown, which is people in these situations might not be able to exercise, move around. So plenty of implications of that for the National Health Service. And through this period, only category 1 procedures, which were designated as people that needed surgery for life-saving or an immediate response for surgery was needed, or maybe even a cesarean section that was done as an emergency. These were the only surgeries that we carried on. Now, clearly, all of that has to be turned back in case we want to revert the clock back to doing what we did before the pandemic hit us. Some very obvious things that should be clear to everybody. COVID-2 is here to stay. It's not going away. It's a pandemic which will become endemic. It's going to take at least a couple of years for the NHS, which is a purely state-based health service, to get back to an even keel. We are all talking of a vaccine which is as far as a year away from deployment, but that may not be the magic bullet for the reasons that Anwar's already pointed out. From what I've heard yesterday, the Chinese have put a vaccine into phase 3 trials. Surprise, surprise, they are apparently going to release that only to the armed forces. So the story goes, looking at the Chinese websites, globaltimes.com. Then, of course, there's this very nasty word, a very nasty phrase, which is winter is coming. This is a phrase which strikes fear into any medic in the UK, because it means our usual winter pressures will probably be hitting us as well. So all of this taken into account, we need to do an about turn with all the work that we've done to increase capacity, because a peak has gone by. But at the same time, we have to maintain some capacity to be able to surge back to the numbers that we need to have in case we are hit with a second peak. The suggestion, the predictions, the modeling is that we will probably have a next peak in September/October, but that is still very much to be seen, because nobody really understands the exact pathophysiology of the disease, how infective it is, so we don't really know. Of course, there are some local issues in the National Health Service. So all the hospitals had huge amounts of debt. That debt has been revoked by the state, but not the interest payments. So even though the National Health Service is theoretically better off, our finances are still dire. We have another magical 3-letter acronym called CQC, which is a major nuisance. It's called the Care Quality Commission. They will start to work again. They were down during the COVID period, but they are the ones who benchmark our hospitals. So you not only have to deal with the pandemic, you also have to deal with the load of people who will come with clipboards to try and benchmark your hospital and say how good or bad your services are. So clearly, lots of challenges, but I think there are some considerable opportunities as well. And the audience will have to forgive me, because I'm taking a very, very practical viewpoint on this. I'm not going into too much detail with the theory behind things. I should talk about the practical issues in here. Now, when we decided to go back to elective activity, we recognized that for the National Health Service to catch up with its elective activity, because all our operations are done on the National Health Service, well, majority of them anyway. So, for instance, to catch up with joint replacement lists, or with elective hernia lists, or with elective gallbladder lists, would take us at least a couple of years. And this has to be kept in mind that all through this whole process, we have to maintain ITU capacity. I'm coming back to that again and again. ITU capacity has to be maintained not just for the COVID patients, but also our non-COVID patients. And we have to make sure that those two areas are clearly separated. So as it is, the National Health Service has a low intensive care bed base. I'm talking about level 3 beds, that is ventilated beds. That has to be doubled up. So we have enough beds for a potential surge and enough beds for our normal intensive care work, which hasn't gone away. Most of the issues that will be a concern when we restart activity, as we have in my organization, have to do with treating patients fairly. So they need to have fair access. So those who need it more, as in if they have a cancer that needs urgent sorting out, they need to come in. And the second one is safety. So we have to ensure that we do this as safely as possible. What you don't want to do is to bring a patient into a hospital which has got COVID positive patients and then end up giving them the infection. Because as I refer to later on, there's a big study from Lancet which came out in the beginning of May, which said that if anybody contacted perioperative COVID infection, after surgery, the mortality could be as high as 25 to 30%, and the risk of pulmonary complications was over 50%. So if people end up getting the COVID infection, that's not a great one. It will only cause further problems. So we have to be fair with both access and with safety. And the plan is that we try and restore all our staff services back to our previously what was called our pre-pandemic pathways, except they don't really exist. So we have to build up new pathways that in some ways parallel what we did before. We do have to keep in mind that one of the drivers, certainly in India, is going to be income generation for the hospitals you work at, because even though all your work has been retasked to look after COVID, you have to pay the bills. The hospital management has to pay the bills. So that may be the elephant in the room for some of us. Certainly in the NHS, we have to restart our work to get back into the good books of the CQC so that we aren't seen to be compromising our patients. As Anwar's pointed out, the National Health Service has a plan for 2021 when we intend to be back to where we were earlier. That's assuming nothing else happens. Now, any attempt at restarting elective work will run with significant risks. There are some risks that are intrinsic to the system, some risks that are individual, and there is an overall risk. The intrinsic risks are the community prevalence rates for COVID, for instance, and the transmission rates. As Dr. Qureshi's pointed out, healthcare workers who are in a patient-facing role tend to have higher positive rates. What that means is you and I run a much higher risk of getting infections from our patients. So all of this impacts directly upon our risks. At the moment in this hospital, our positive prevalence rate of antibody is about 12 to 13%. Compared to that, a sister hospital, which is only about 45, 60 kilometers down the road, their rates are about 4%. So different areas will have different prevalence rates. So we have to be slightly aware of that. Then other things that make up the intrinsic risks are the infection control protocols that are in place, the personal protective equipment. This has been a major issue in the UK because we are a state-run system. All of us have a strong belief that a large part of the PPE problem was because of costs. So the system wanted to keep the cost down. Hence, there wasn't enough PPE in the system, even though there's plenty of money to go around. The UK economy is just about the size of the Indian economy. So you can see for yourself that it's a relatively rich country, This is not one way you would have expected to have problems with PPE, but yes, we've had them. Another issue with intrinsic risk is what's called the ACT, the aerosol clearance time. Now, Dr. Qureshi's pointed out the issue of aerosol generating procedures. So my specialties come up with this concept of what's called the aerosol clearance time, which means that it's not necessary that a virus be in the air, but if there's potential for that aerosol to be cleared, we need to make sure that that clearance is complete before we go on ahead and have another procedure in the same theater. So for if, as it happens, I've got a knee replacement on the table right now as I speak to you. Once the knee replacement is done, this theater has about 20 changes of air per minute. So the aerosol clearance time would be 60 divided by the number of the room air changes. So that becomes 60 divided by 20. That's 3 minutes to clear the area of about 2/3 of all the viral load. In real terms, it means you need to wait for about 5 or 6 of those changes to happen before you can go on ahead with the next patient. So that means in this theater, I'm going to be standing down for about 25 minutes between cases. Now, that's part of the intrinsic risk. Extrinsic risks have already been discussed quite clearly by Dr. Qureshi. He's talked about how ethnicity, how age. So anybody who is over the age of 60 runs a high risk. Anybody with the body mass index of more than 35 runs a high risk. Diabetics, previous respiratory disease, anybody with a previous cancer, anybody who's a male sex, anybody who's immunosuppressed, anybody with chronic kidney disease, any cardiac conditions, all of these people are at high risk. Pregnancy is a major question mark because we aren't sure, but if we have colleagues who are pregnant, it makes great sense for them not to be in a COVID positive zone. And then individual risks also have to talk about what do we do with COVID positive staff. So if people like Dr. Qureshi who have got antibodies come back, how safe are they? And as he's pointed out, there's not enough information about whether or not these people will have immunity. But the suggestion seems to be that at the very least, they'll have 2 to 3 months worth of some immunity. So as far as we are concerned, COVID positive staff should be treated the same as everybody else. So there is that issue as well. And overall, none of this can happen, that is restarting elective work without doing it in a safe environment. So some of the buzzwords which are circulating right now, Dr. Qureshi has alluded to some of them. We talk about cohorting. So currently the National Health Service has this very interesting color code. So you have red areas which are COVID positive, you have green areas which have allegedly no COVID, and you have amber areas which run an intermediate risk. It's actually easier to think of these as low, intermediate, and high risk rather than as COVID-free zones. The reason why I bring this up is my hospital management teams have a lot of difficulty in understanding that a green zone doesn't mean that there is no COVID. It just means that the zone has a low risk of having COVID. And then there are issues like social distancing. Now, social distancing doesn't really work in an operating theater where you have a surgical team, a scrub team, and an anesthetic team in very close contact with each other. Even in the anesthetic coffee rooms right now, you can imagine social distancing is quite difficult to work with. Though as I've noticed on the Zoom meeting, most of the people who are there are wearing masks, which I think is very, very sensible. Testing numbers already alluded to. PCR has up to a 30% false negative rate. Antibodies, we are unsure of the significance. Another issue that has come up, which may be local to us, but may come to India as well, is that staff members who have got antibodies, at least 1 or 2 of them have been refused insurance. So staff members who have went to buy life insurance in case something untoward happened to them, who turned out to be antibody positive, were refused insurance by insurance providers on the basis that antibodies potentially indicated underlying disease. And since nobody's sure what the long-term outcomes of COVID are, it could be pulmonary fibrosis, it could be any of a number of things, they are not happy to offer them life insurance for at least another 3 months. So this may become an issue, something to keep in mind. It is becoming an issue already in the National Health Service at the UK level. Then in my Royal College of Anaesthetists has circulated what they call the 4S formula, which means you need to do the right patient in the right place with the right staff with the right kit. So all of those things have to be brought together. Any decision about how to move to restarting elective work has to be multidisciplinary. It has to have a buy-in from all staff, nursing staff, primary care teams. It has to have a buy-in from the portering staff, from the radiology teams, everybody. It can't just be a management implemented decision. Any solution will have to be local, because the issues that beset you are very different from the issues that beset the NHS. They are very different from the issues that beset my colleagues in America. I know for a fact that in Delhi yesterday, so I was speaking to some of my colleagues there, black market for convalescent plasma. It's not an issue that we've seen here at all, because convalescent plasma is not used at all, or has been used very, very sparingly with questionable benefit, but our numbers are small. There's right now a big black market on remdesivir. Somebody was offering a dose at 70,000 rupees per dose yesterday. And this was the number that was floated around till one of my other colleagues, who's also a doctor, managed to get a dose for 2,000 for another doctor. So there are issues that don't really impact upon me, but will probably have a large amount to say in how you practice there. So any solution clearly has to be local. For those of us who are in the developed world, I think two things have to be borne in mind. One, you have to be aware that anesthesia and critical care are Siamese twins now. They are linked together at the hip. Had the two specialties been separated out, as was the plan in the UK at some stage, we wouldn't have been able to manage the surge with COVID-2. And I suspect that will be an issue with places like the US, where they have very large numbers now, 2 million plus infected, with quite significant mortalities. I know that in New York, this has been an issue, speaking to my anesthetic colleagues there. And in this NHS climate, we have the accelerator and the brake analogy, which is you can't run one without the others. You can't just accelerate, you need to have the brake handy. So this is COVID-2 and elective surgery. So the two will have to work in tandem, and we just have to accept the fact that with endemic COVID-2, electives will have to do the best they can. Anyway, with all of this in background, we decided to put some local solutions. We were lucky because our hospital has a remote site which could be designated a green zone. This was not used at all during the COVID period. So we set up a low-risk green zone or a low-risk site. We've had issues with staff, as in, are they meant to be purely the high-risk people who should be redeployed here? How do you staff them? Do you run them on the Chinese model? The Chinese experience from Zhejiang University, which dealt with the Wuhan problem, was to get staff that they kept for a month. So they rotated them for a month, then stood them down for 2 weeks. After isolation, they were released back to the families. Do you do that? That won't work in the UK, but it might work in other places. Do you have dedicated staff who only do low-risk surgery, as in they get swabbed regularly, they have antibodies tested to make sure they're negative? And then how do you deal with staff who move between various zones, or even anesthetic staff who are on call? Now, none of this can happen without staffing being thought through. For instance, in my own department of anesthetics, as I am working on a green zone, I'm not doing any on-calls. So some of my colleagues have to pick up the slack in the background. So issues like that will affect how we deal with any local solution for restarting elective can work. The second key issue with the local solutions is patients. They have to be the correct ones. You have to select them. You have to screen them beforehand, because all of these patients are going to be coming in after 2 weeks of isolation. That's mandatory. So any patient coming in for elective surgery in the NHS right now will have isolated for 2 weeks, and will 3 days before the procedure have had a PCR swab done, which would have been negative. Since they have already been isolated and they are screened, you don't really have a chance to cancel them. So cancellations are completely unacceptable. So you really have to make sure that you have the right patient, and you don't end up with somebody who's an uncontrolled diabetic because they could not go to see their practitioner because of the lockdown. Then we have simple local issues like blood samples in the NHS can only be stored for 2 to 3 days for a group and save. So how do you get the blood samples from the patient if they're isolating? So we've got teams that will now go out and get the blood samples from the patient at the same time as they go for the nasal swab. So quite a few issues that have to be kept in mind when we look at patient selection and how to deal with it. The site is really important. Any site that is chosen for surgery will have to deal with all kinds of patients, including the higher anesthetic risk, as in people who have multiple comorbidity. For instance, I've got a patient on the table right now who's an 87-year-old having a knee replacement. Her kidney functions are about a quarter of normal. Her eGFR is in the late 20s. She's also got significantly deranged liver enzymes, and she's got a strong background history of ischemic heart disease as well as some background confusion. Now, this is a patient who will need level 1 care afterwards. So unless and until I have that facility, I can't do her in a green zone. If I do her in a green zone, I have to make sure that the staff left behind are able to recognize a deteriorating patient. The staff in here have to have links between themselves and what we call the critical care outreach team. This is a nursing team derived from intensive care who will go and look at any deteriorating patient. Basically, they save my time, the anesthetic time, and in turn, they liaise with the anesthetic and the intensive care team so that if we have, say, an elective patient who's unwell or has deteriorated, we can pick them up as early as possible and move them to intensive care. And that site profession must be able to transfer to an intensive care unit, because it is likely that anybody who has elective surgery, particularly if it's high risk, and even though I'm talking about a knee replacement, the same thing holds for major colorectal cancers, which Mr. Garimella will talk to you about later on. We need to have provisions for intensive care to support them, because we know that the best surgery in the world needs to have good support post-operatively to ensure that we can get the best outcomes for our patients. Any site must have some provision for cancellations. So imagine you have an overrun for a list, and anybody who's an anesthetist will tell you that they have seen overruns all the time. So you have surgery which is unexpectedly longer in duration. The femur violet is being deemed fractures, so you could have an overrun. Maybe the PCR results for the patients aren't back just yet. So you may have cancellations, even though they should be kept to an absolute minimum. If you have a cancellation, you now have to work out how you're going to get the patient back home so that they can be relisted, but they need to be kept isolated till then. And then they need to have a repeat swab as well. So any cancellation has to think itself through before you go on ahead and say, yes, we are canceling the patient. So plenty of things that need to be thought through when the site is being planned. There are quite a few challenges that currently are there. So in theaters, it's infection control, and that is the paper I was talking about, the one which was presented in the Lancet. And this talks about, as I said, nearly a 24% mortality in anybody who gets a pre or post-op COVID infection with any kind of surgery. Then the challenges are testing staff and patients with that false negative rate that we've got with the nasal swab, the questionable antibody testing. Then the bit that was already kind of alluded to by Dr. Qureshi, which is if you're working on a green side, do you downgrade the PPE? Clearly, downgrading the PPE has benefits for the organization in terms of cost, but if you have got a high-risk group of doctors/staff working there, you need to think that through. Consent for your patients has to be informed. Patients need to understand that they run a much higher risk of having complications afterwards. And without that understanding, at least in this climate, in the developed world, you are likely to be up before a lawsuit before you know it. I think some of that's coming through in India as well, but maybe not to the same degree as we face in the UK. Obviously, the UK is a lot better than the US, but I think this is a problem that has to be dealt with. And probably the biggest issue from the surgeon/anesthetist point of view is the reduced throughput. With the need to wait for any aerosol clearance time, with the need to don and doff your personal protective equipment, anesthetic rooms, which is the place where traditionally anesthetists would anesthetize a patient before taking them to theaters, have been taken out of circulation. Post-operative care units might have been taken up by intensive care. Our level 2 beds might be limited because our intensive care capacity has not yet doubled, so that we can carry on doing work as we did before. So that reduced throughput is a major problem for us. Now there are problems at the intensive care which are really, really important. We have to maintain a surge capacity because, as I said earlier, we expect COVID to be back. Maybe not to the same degree because we've had a disproportionate amount of deaths in the older age group. So possibly our sickest population has been in some ways weaned. We've lost them, but we will still have a surge. We have to maintain a separate COVID and a non-COVID areas, even when there are no patients who are COVID. Currently in my organization, we only have 2 patients who are COVID positive who need level 2/level 3 care. But even then, we have to maintain a COVID 2 area because if that happens, we can't afford to contaminate a non-COVID 2 area with COVID patients. We have to maintain the capacity to retask staff as is needed. So we may need to bring our obstetric/orthopedic/ophthalmic/gastroenterology colleagues back to help out in the intensive care as needed. All of this can't happen without monitoring the regional and the community infection rates and the transmission rates. So all of this is a very big piece of work that has to be joined up. And all through this, intensive care is constantly working on trying to release any capacity they've taken up from post-operative care units and theaters back to the surgical divisions. As soon as they can be spared, they need to come back so that they can pick up the slack with picking up elective work. Cancers cannot wait. Urgent operations cannot wait. And if somebody's 87 and needs a knee replacement, they really need to have that so that they can get their mobility back. So we do need to work on this. As I mentioned earlier, there are loads of opportunities, and one of them is this discussion that we're having, which is remote. So I think it's absolutely amazing that we can speak across the internet and have a two-way exchange of views. I suspect India has huge patient numbers and huge experience. So there'll be a lot that the NHS is going to learn from the India experience in the next few months and years, which is why having this telecommunication is really, really important. So this should be a two-way process, and hopefully in a couple of months' time, I'll be hearing from colleagues at the Indian end about what we could do in the NHS to deal with our next surge when it comes. Locally, telemedicine has come to stay. We have e-prescribing. One of the issues that we have with operating theaters is any notes that are made in the operating theater, particularly if it's a COVID positive patient, are potentially infective. So we've gone to e-prescribing, we've gone to e-records. Hopefully they are paper-free, so we are ready for the next pandemic when it comes. And as we know, the wet markets in Wuhan have not stopped working altogether. We know they are still in existence, so maybe the next pandemic is a few years down the line. And the NHS, we've gone to remote clinics, which have really been useful. We've gone to video clinics that nurses do. We have gone to anesthetic clinics that are remote. I run virtual multidisciplinary clinics where if there are complex decisions to be made, for instance, I have a 80-year-old lady coming in next week for a major gynae cancer procedure, but she's got several medical issues. So I've set up a meeting with the surgeon, the gynecologist, the oncologist, as well as the lady and her family and the local practitioner. And this will be a Zoom or a GoTo meeting or a virtual meeting. And we'll then discuss the thing. And since every party is aware of the risks, we'll then be able to go on ahead. So having a virtual multidisciplinary team is very, very useful. At the nursing level, they have been taught how to use camera on wheels. So we have high resolution cameras that they can move around to show the details of a patient to the surgical staff or the anesthetic team or the intensive care team about what the problems of the patient are. This is really, really important because, as Anwar pointed out, with conditions like SARS-CoV-2, we do not want to have more staff exposed than necessary. So if we can reduce the amount of, say, medical staff who have to be exposed to these patients, we are actually reducing the likelihood of our own colleagues getting infected. So that's good. We also need to be looking at how we can create level 1 and level 2 beds, because as I mentioned earlier, you can't really do complex surgeries without level 1 and level 2 beds. This might be an opportunity for the NHS to see how we can use these beds and retask them for any future intensive care expansion as will be needed with the next surge. And it is really, really useful to take advantage of this to upskill our staff by training them to deal with slightly more complex things. So all in all, I mean, I think we have a fair few operational issues. But unless and until we look at the processes and have an iterative feedback loop, so we assess the process, see how it's working. We start small, don't do major cases, 5 major cases, then let's start with 2, see how it works, go up to 3, and then work from there. We should be able to do this. But whatever work we do has to be clinically led with strong management support. At all stages, we have to be flexible, because not only is SARS-CoV-2 likely to come back, as I said, we're expecting it to come back in September or October. We also in the NHS have central policies that change regularly. So basically, be prepared for the next surge is my message. And I think that's all I have to say. And thank you all for listening. Happy to take any questions.
Thank you, Sandeep. We will move on to the next speaker, Mr. Garimilla, and then we'll come back to you with questions, if you don't mind. So next speaker is Mr. Garimilla. He is a consultant colorectal surgeon and laparoscopic surgeon in University Hospitals, North Midlands, based in Stoke-on-Trent. He's been instrumental in drawing up the plans for elective surgery restart in their trust. Veera, please unmute.
Thank you, Murthy, for the invite. So I'm going to present on the surgical side of what's been happening, what we have done, and how we have changed things. So this is briefly my profile. I worked everywhere. Started in India, came to UK, went to America, and then back to UK. So I do most of colorectal and general surgical operating, and I work in a university teaching hospital. So unlike in India, for us in NHS, most of the hospitals have stayed open during pandemic, and we did continue all colorectal cancer or GI cancer operating throughout the pandemic we have done. Unfortunately, in this country, we have the second largest COVID-19 related deaths in the world, with a GDP more than India, with a population equal to that of our state. So not very good state of affairs, and I don't really, I think there is no correlation between amount of money versus how COVID has affected us. For us, elective surgery, as I mentioned earlier, has been going on throughout, and we have been, we have been doing all cancer surgery. 2-week waits, that is how we get the referrals. Initially they fell, and then it has picked up, and the general practitioners are sending the patients here up to about 70% capacity. Previously, we used to see all these patients in the clinic and then send for investigations. We have changed it by something called triage to test, where we look at the referral, look at the symptoms, and then send for investigation directly there without getting these people into clinics, because there's risk of catching COVID from coming into the hospital. Investigations, we have changed from using more of CT scan, which is less invasive, and colonoscopy only if it is a CT diagnosed cancer or if there is a rectal cancer. CT virtual colonoscopy has also gone down because of worries regarding insufflating somebody with 6 liters of carbon dioxide rectally during the COVID environment. So it is slowly coming back up. Management of patients diagnosed cancer, we are still seeing them. We are still old-fashioned. We feel that we have to see the patient, explain it to them face to face. We were taking some precautions, including disposable plastic apron, gloves, face mask during consultation, and use a face shield if we have to examine the patient. So this has been what we did in clinics, because we do see videos from different countries where a full PPE, including FFP3 masks, are used even for consultation, but we have not used that here. Preoperative assessment for patients who are diagnosed. We start off the standard pre-op assessment. In addition, we have added 2 weeks of self-isolation for patient and family. And in some cases, people who are working, we are having to give letters for their work. Key workers, people who are doing important jobs during this pandemic. And we do a COVID swab 72 hours before surgery. And if they are negative, then we do surgery. Patients who need level 2 care, high dependency, postoperatively in colorectal, it is quite less. We do a CT thorax 24 hours prior to surgery. And unfortunately, most of them are being reported as indeterminate. If it is indeterminate, then we have to postpone for a week. Operating theaters, as Dr. Saxena clearly explained how we were doing things. We have had a unidirectional flow of staff in the operating theater, exits and entry, clearly marked, staff wearing the PPE when they come into the operating theater, keeping minimal number of staff, and patients have been anesthetized straight on the operating table. Anesthetic safety, Dr. Saxena has gone into this, so we don't need to say, but full PPE for anesthetists and their assistants who are helping them to anesthetize patients. Patient selection during initial part of the pandemic, we only treated good, healthy patients less than 80. That is young for us in this country, of a significant population of over 60s. So curative cancers we have operated on during the peak time, and we kept a list of patients who were curative cancers but slightly higher risk, and so we left them until the peak had finished, and then we did the surgery on those group of patients as well. Only surgeon and one assistant. Unfortunately, we, being a training hospital and teaching hospital, training for juniors has been affected because we made a rule that we have to get in and out as quick as possible. So the surgeons operate by themselves rather than leaving it to trainees or trainees assisting the trainees. So that is how we managed full PPE, including double gloving we have done. Laparoscopic surgery has been controversial. The Royal Colleges initially said, don't go for laparoscopic surgery. Maybe that will generate more aerosol and that is risk. But we, in our trust amongst the surgeons, we've had a discussion and continue to do laparoscopic only surgery. We use something called an air seal, which is an expensive piece of kit with no strong evidence even to date. It was available, and so we used it. But unfortunately, even the consumables for this kit are expensive at about 200 pounds per patient for the consumables that you use for the air seal. Some procedures we've used just a smoke evacuator with particulate filter, which is better, we don't know. At the minute, there is no strong evidence in either direction. But in terms of taking the capnoperitoneum off, we have sort of done it slower using the smoke evacuator rather than letting it all go through all the ports and at one time. For initial 10 or 12 cancers, we made a stoma for all the surgery, but then we reassessed and said, maybe if we are getting away, not having any problems, let us anastomose these patients also. And so subsequently, we have been anastomosing both right and left-sided colon cancers. Post-op standard enhanced recovery, we are expediting stoma training and discharge safely as soon as patient is fit with good support by telephone. And if patient needs to come back, we give them a gate pass so they can come into surgical assessment unit 24 hours a day, 7 days a week if they run into any problems or they're worried about any issue, which patients have used judiciously, and it has helped both us and as well as the patient. Post-operative management has changed. It is telephone consultation completely now. During the peak of pandemic, chemotherapy was kept on hold, but now has restarted. We have a separate hospital for chemotherapy. We took over the local private hospital and we've been using chemotherapy there. In terms of rectal cancer, chemoradiotherapy to downstage has gone down, and we were just using radiotherapy and short course. So those were the changes we had to make. Endoscopy predominantly everywhere. I've checked in a lot of hospitals by friends. Endoscopy has changed completely. They're using full PPE for upper and lower GI endoscopy, working between two endoscopy rooms with air changes and giving 20 minutes before cases. And number of endoscopies as a result has gone down. So we used to do about 6 colonoscopies per list. Now we are down to about 5 or equivalent number of flexible sigmoidoscopies. Outcomes have been good for us. Maybe had 22. We are a team of 22 GI surgeons, upper and lower GI. So far, not one of them have needed any admission or has been positive for COVID. Only one post-op patient acquired COVID-19 infection. She went home and 2 weeks later presented with the quite fulminant lung changes, but she was well. She did not need ventilation. She went on to a COVID ward and was discharged home. No mortality, and in fact, I think these are our best results for resection during this period. I don't know, is it just luck or patient selection or consultant surgeons doing the operations all by themselves? And keeping an eye on these patients very closely because there is nothing else to do. Throat swabs have been done for all the staff so far. Everybody's been negative. Antibody tests they are doing, and I think across the hospital we have about between 15 and 17% positivity among staff. What that means, nobody knows. This will probably give some professor an OBE, but in terms of what it means, we still don't know. Way forward, I think consultations, as everybody has been saying, will become predominantly telephone and video consultation. I think maybe the rules will have to be changed in India also, where telephone consultation was a complete no-no, and I'm sure there was a government order also that's come out saying do not give any advice over a telephone and do not use telephone consultation, but I guess that will have to change. All meetings, international meetings, everything has gone to videos, and face-to-face consultation has become limited. What do we do? Currently, we are doing the priority 1 and 2, which is within 24 hours, that is emergency surgery, and within 2 to 4 weeks, this is predominantly cancer or any other similar life-threatening surgery that we are doing. We have to go forward in the next few months into stage the priority 3 and priority 4 cases, because it's not just cancer that causes problems to patients. There are several other conditions. More patients we have noticed anecdotally coming in with complications from simple things like inguinal hernias, which would have been repaired electively, but now they are coming in with either incarceration or obstruction. Patients with inflammatory bowel disease do not have a pathway, so they're coming in as emergencies and going for medical treatment and then coming down to surgery. Steroid use for IBD has gone down. We are changing all patients who we put in acutely on prednisolone. We have gone to using steroids which are not absorbed systemically as much. Endoscopy, we're looking at things like colon capsule and getting the training to interpret the images that come in on video. So as we know from CT virtual colonoscopy, about 1/5 of patients need endoscopy. So if we can get them shifted between CT virtual colonoscopy and colon capsule, then the load on fiber optic colonoscopy will go down. But still, as a the diagnostic investigation, it is still useful, and also for therapy as well. Zoning of hospitals, I don't know whether this will be successful, because currently the problem is with how do you define, especially in a hospital, in NHS, where you have acute and elective surgery in the same hospital. So people, including porters, staff members, mingle between the green and blue or purple sites. So, and the swab results, there are false positive. How are these going to have an effect on maintaining pure green sites? We still don't know. Every time we are having a drawing of a green, this is the green zone, this is purple zone, and so they have to redraw. So still, this is ongoing process. I think the best option waiting at in priority 1 and 2, then we can use the operating theaters for 3. So this is how it's being done, and probably this is how it will work in most places, having a separate setup for elective surgery, separate teams. This will be a big, huge manpower challenge, because running 2 centers with the restriction of staff that we have now is going to be difficult, because even with 10 of us colorectal surgeons, we provide acute service as well as elective, and now dividing into a cold site and an acute site is going to be a difficult thing to achieve. Ongoing situation, we have to see how the virus pans out, whether there will be another surge, or if there is going to be a vaccine. All this will dictate what's going to happen in the future. Thank you very much.
Thanks, Veera. The last speaker is
yourself.
This man in this dodgy suit. So the left side is how they have tested me for that respirator. On the right side is the pretty picture that is the outcome of that respirator, wearing 6 layers of it. And that's all because of these guys. So they basically said all these things. They said 9 points. This is for emergency and elective surgery from the intercollegiate guidance. So the current thinking is we passed the peak. So some of the realities of having passed the peak are being suggested by the Royal Colleges. So like all the previous speakers have said, it's a combination of local factors, national guidance, availability of PPEs. So obviously not trust at the minute, at least for the surgical team, we don't seem to have much issue. And then various guidances. We have one dedicated person who's been designated to follow the guidances at the minute. And that's their full-time job. He spends a lot of time on Facebook as well, chasing all the guidances. So the data is still emerging, and we know there is a landmark paper in Lancet which talks about 25 to 50% risk of mortality post-op, and all the colleges say it's substantial, and we'll keep watching this column in future. So elective major surgery, I won't take any more of your time talking about it because the previous speaker has done better than I can. The emergency surgery is my remit, and in terms of emergency surgery, there are some important and significant considerations from our local and our national guidance point of view, which we are following. So majority of the patients, listing them for emergency surgery is now almost a multidisciplinary decision, and more than one consultant is involved in making that decision, which I think is a safe process at the minute. That's because of the risk of exposure to an unqualified in terms of COVID patient, to the staff, to other patients in the ward, and to all the auxiliary services. The risk there seems to be slightly abated with routine HR CT chest, high resolution CT chest. We do have rapid testing methods, but we have a guidance from the college asking us to treat every patient who gets an emergency general surgical procedure as a COVID positive patient, and that's how we treat them all. So the system is for full PPE, respirators and all that. Perform the procedure. If it is a lengthy procedure, we have taken turns to perform parts of the procedure because it gets really hot, really boiling in that kit. Even with the respirators and the fans and what have you, it is really the most uncomfortable thing. Leaving a permanent dark mark on my nose. I wasn't born with this. So the next thing is to continue insisting on safe practices. So the staff do not lose sight of performing these procedures safely. And keeping personnel and systems engaged is an important challenge. Surgical plume smoke, the previous speaker has spoken about this. In our place, what we have is the electrocautery is connected to extraction systems, and abstracts have extraction systems in them. So we have started performing majority of the procedures laparoscopically or with these smoke extraction systems. So rest of the slides are as described in the college website and as described on the slide presentation here. There'll be ongoing reviews from the college. There'll be ongoing reviews locally. But this is our routine practice for all the emergency surgery currently. And that's all I have to say about it. Now the floor is open for discussion. Dr. Saini, please take over.
Yeah. Thank you so much. I think it's the most elaborated way each speaker has given their opinion. My question to Dr. V. Rabhadram is, yes, you said about we are doing all kind of surgeries. Now, are you maintaining a negative pressure? Because for a COVID patient in an OT, you need to have some negative pressure because most of the OTs are positive pressure OTs. Are you maintaining something like that? If suppose a COVID patient comes?
For COVID patients, if we are doing surgery, these patients have, because the capacity in theaters has increased, room capacity, because we are not doing elective surgery. So what we do is we do one emergency surgery. If it is a COVID positive, we have a designated theater, set of theaters where we do them, and non-COVID patients are not done in that theater. So we keep that separation between COVID and non-COVID theaters. And also in between cases, as Dr. Saxena mentioned, we keep the air changes and make sure that we give enough time for the theater to clear out before ventilation theater clears out before we do the next case, even for elective surgery.
So
can I just add a point to this?
Structural changes. So you have not brought any structural changes in that.
No.
It's not making it a negative pressure, OTs.
No. It is structural, as in our theater complexes. So we have about 34 theaters in 3 sets. So we have 2 of 5 each, and then the rest of them in one big complex. So we use one group of theaters in that 1 to 5 as a designated COVID theater. So anybody who is positive, who needs emergency surgery, will get operated in those theaters only. So there is no intermingling of patients coming into the same theater complex, COVID and non-COVID patients.
So one is separating the 2 OTs, and secondly, you said that you keep a time gap also.
Yes.
Around 20 to 30 minutes between the 2. So even if the positive patient comes, it's not there. Now, second question comes to me. It's addressed to, I think, Dr. Qureshi, that we have now air conditioning. India, there's a lot of heat is there. The temperature is very high. People have perception that if we work in an AC environment, because our ACs are window ACs, the same air is circulating, and where the patient is also being there and doctor is also sitting over there. So sometimes they stop the AC. but in this kind of heat, it is very difficult to work. So how you are managing in UK? Is there, you have a separate AHU or you have the same issues of having the same environment you are working?
Yeah, for us it is completely closed, no windows theater system. So we do have air
I'm not talking of
conditioning.
theater now. I'm talking of a ward in which if your patient is in a ward, there you have a temperature which is AC controlled, and in AC, in that the same air is circulating.
Yeah.
And the
In
doctor is
closed
also
environment,
there.
yeah, in closed environment, whether you have AC or not, I think it is the same problem. That's why we are trying to get a zoning where you have a ward which is only COVID patients, ward where we have no diagnosis, and another one which is we know for certain that patient is asymptomatic and COVID swab negative, so they are all in a separate ward. So there's
Sandeep,
no intermingling.
you might be able to take this one because of our interaction with industry. In terms of wards, how they are zoned out, the respiratory wards are negative zones. Okay, the ward 22 and what we have. Sandeep, please take this question. And Dr. Bhaskar Garu, I'll come back to you because you and I did a piece of work on this yesterday.
Okay, so getting back to the question that was just put in there, the point is that with this COVID, the main thing is not so much the air conditioning as it's the number of air changes. Even wards tend to have air changes. Theaters tend to have about 20 air changes per minute. Wards tend to have about 1 air change every 30 minutes or so. So strictly speaking, because of our completely controlled environment, it is the number of air changes that determine what is the infectivity of any particular patient to either the staff or to other patients in the area. So it's about air changes rather than about air conditioning. And yes, I can understand the heat and it is very different from the temperatures here. Completely understand that.
So it depends on the extracting systems as well. And currently, the people who are in the industry, both Howard and Interfern, have said they have not been asked to provide extra air handling units. Now, some of the Indian hospitals I know, Dr. Bhaskar Agaru, you know, you're trying to get something sorted in your own theaters, aren't you?
Yes.
So they have installed extra air handling units to create negative pressure per air exchanges at the end of the procedures. And we had an interaction with industry in India and UK yesterday. We did a meeting with them to see where this trend is going. And there seems to be a trend in India to install new air handling units for negative pressure and for air exchanges with natural air and connect them to AGSS, anesthetic gas scavenging system. But in the UK, there have not been many units which have changed their air handling for COVID alone. This has been previous evidence from Italy. That's the reason why industry is not recommending it.
But my question is, Dr. Saxena, we have most of the places and window ACs. There in a ward, if a patient is having a window AC, how to now manage these kind of things?
We don't actually have wards with window ACs. That's the thing. All of our air conditioning is central. So you have ducts in the ceiling, so it flows through. So yes, I mean, you have a very individual issue there. But I think it's about how many times, as Dr. Murthy's pointed out, the bigger dilution you have, the better it is. So if you have an open air unit that brings air in, that's the best one. The reason why we have not moved to negative air in our theaters is that retasking them to positive, which is needed for reduction of infection control, is actually quite difficult. So you can get the same units to pull out the air, but if you do that, you increase the chances of infection. So traditionally, all operating theaters run on positive pressure, so that there are about air changes 20 or so per minute happening all the time. So we can't switch from one to the other, which is why we have not gone to negative pressures in our theaters. But I understand your problem with the AC.
Okay, fine.
No, Shiny.
Yes,
because that what you're talking about split air conditioning, that is circulate the air inside the ward only to circulate. You won't get any fresh air. And to get a fresh air, is a central air conditioning with a air handling unit is the best one. Otherwise, just open the doors, open the windows, treat like a normal ward. I think it is better than the air conditioner.
I think you are right, sir, that people have to understand, those Indian people have to understand, and if they are having a window AC, they should keep their door open. That's why I said this question, that keep your door open so that fresh air is coming, because window AC is not giving you like an AHU where the air circulation is there. The same air is being continuously being done. So have a window or an exhaust fan open.
The Saxena, what you are planning in our new critical care and our operation theatre, your regular AHU and other thing positive test will be added to this separately. You are making a negative pressure at either one or two times a day, or maybe end of the procedure one operation. You want to on the negative pressure, you want to just get the wire load down, and you go to positive pressure. And it can be automatically, it can be done, or manually it can be. You're getting done within 1 month time in our hospital. Yes, Sunny.
Could you unmute yourself?
My another question to you, Dr. Dr. Murthy, that you said you are getting your staff tested for RT-PCR frequently. How frequently you are getting this staff tested for this, or antibody testing, whatever it is?
So it's not a repeat performance. So what we had when we were about to start our elective activity was we all had our PCRs done, nasal swabs and throat swabs done. And then when antibody testing became available, we all have been tested. So there is a small database that currently has record of all our antibody testing, but we are not repeating it unless until there is an issue. Sandeep, do you know anything else different?
No, the facility exists for staff to be tested regularly. This has been discussed, but then how frequently are you going to test them? Ideally, you should be testing them every 2 weeks. And that really does not make any sense. So I think rather than go down the line of discussing testing, we've gone down the line of waiting for the vaccine to arrive. And that will probably be the only answer to our problems.
Pragmatic.
I can't say.
So it's for antibody testing, are you testing IgM, IgG, or combination of these two?
IgG is what we have been given to understand.
What?
Well, IgM is also tested, but it is short lasting. They're testing IgG, yes, but
G is what we have been given to understand is what's being tested.
Yeah, but what's the significance of it? I mean, how useful is it?
No, it has a significance because IgM, as you said rightly, that it is a short period of time. Then it means the patient is infective. Rather than we have to go for RT-PCR, this healthcare worker cannot be allowed to work in that setup. So if you are testing IgG, probably patient is immune, so he can go for a work. But if it is IgM positive, then they are not, and they have to be tested for RT-PCR. Is it
based on the current evidence? We are not that sure. At least, yeah, we are not that sure.
Okay, I just had that initially in the initial stages we said that UK had around 3 lakhs of patients, but the mortality was 44,000, which was very quite high as compared to any other European country. Even in India, if we say that we are 6 lakh, we have a mortality of 18,000. So what you feel that, what was the reason for this high mortality in UK?
Well, I can pick up part of that question, and part of the story is one, the counting is very good here. The British are very good with counting. Take that for granted. 2, our care homes have had a disproportionate number of deaths. Those deaths have also been included into the total death count. So all the people who are above the age of 80, I think roughly about 15 to 20% of our population there has been affected by COVID. So that's one major source of mortality. And the second one, I think, is probably because we went into lockdown too late. We had scientific advisors who were talking about herd immunity. When you don't know the disease, how can you talk about herd immunity? But I think that's part of the story. I'll let Garibla and Dr. Mr. Murthy take up the rest of the story if they have any other.
Anything? No.
We have very little knowledge of this at the moment to make a an educated guess on the outcome.
Okay, now I come to another question.
I can give you a number there. I can give you an interesting number there. Maybe I'm talking from a very specific viewpoint, but in UK, for instance, our intensive care beds are 1/4 of what Germany has. Germany has a very low mortality. We have a very high mortality. I have said to the powers that be, look at the death graphs and compare that to intensive care bed base. You might find some answers there.
Dr. Saini, can I find a similarity between you and Dr. Saxena? You're from Indian Medical Association, he's from British Medical Association. There you go, that's the connection.
Probably I feel that the UK had, because you are, I agree with you, the older peoples are more there. India has a younger population, so relatively maybe because of that reason this is there. And secondly, I think you started these lockdown procedures quite late. And by that time, many people are infected, and more so, I think the older people got infected. Any idea about in this 44,000, how much were older and how much were younger people? Older means 60 years above and 60 years below.
Well, our mortality from the community, which is where most of our care home mortality is roughly about 15,000 of that total number. So I'd say maybe 1 in 3, maybe 1 in 4, somewhere around that much. So quite a large number of the mortality comes from the community.
Okay. In one of, I think Dr. V. Rabhadram said that prior to surgery, people are given 2 weeks of isolation. This is what is correct?
Yes. So currently what we tell patients is, because there is a partial lifting of the lockdown process, we tell once we give the patient diagnosis of cancer and they need cancer surgery, we tell them on the day, your surgery is on so-and-so day, and 2 weeks prior to that, you're self-isolated. So you're not going out. It is voluntary. We ask them to do it. And after the self-isolation is finished, 72 hours before the procedure, they come in, have a swab. And if that is negative, we do the elective surgery. That's the current guidelines.
Just to add to what Mr. Garimella was saying, swabs are normally done at the patient's home, because if they come into the hospital, you are now bringing them into a potentially positive zone. So our local policy is all our patients get swabbed at home, and they have the blood test at the same time, just to make sure they don't accidentally get infected.
No, for us, unless they are elderly and
Sorry, he had a phone call. Dr. Saini, could we move to the next question, please?
Yeah, each one of you mentioned about the second surge. What that means, second surge? Were you thinking that there will be a mutation will be happening, or are you thinking that people will get relaxed and then they will be getting more transmission of the disease? What do you mean by a second surge you are expecting September and you said September, October?
Well, Dr. Saini, you know how it is with infective diseases. Infective diseases subside when you reach a certain amount of people in the population who are infected. Because when that many people are infected, the disease can't transfer any further. So we expect the second surge because the disease transfer in the population is still quite low compared to what it needs to be to control it. So if we were to let this disease run unchecked, eventually we would expect about 70% of all the people to be infected, and that's when the disease would stop, because we would have enough people who would be immune from it to let the disease die out. So that is why we are expecting the second surge to come, probably because I expect from tomorrow pubs are opening. You will see big queues outside the pubs. People will be drinking themselves silly, strange things will happen. I expect to see our infection rates go up. And this is the developed world. You can't stop anybody.
Okay, that's where we were thinking that people. Please carry on.
Excuse me, gentlemen. We've come to the 2-hour mark for the webinar. If we could restrict the number of questions to complete the webinar, please.
How much time is left?
2 hours.
No. How much time is there now?
We are done. We are done with the time. Thank you. I think we are.
I think.
Thank you very much. Thanks all for.
I think well done, all the people. Excellent. I think take our message to all the people, and Rajahmundry and our faculty. All thank you, Murthy Garu. Thank you, Garimala, Saxena, and Sandeep, and Shiny.
Thank you very much. Thanks for organizing this.
Thank you.
Thank you.
Bye now.
Thank you.
Namaskar.
Thank you.